session with Professor Hussam Al-Arabi, the chairman of the cardiology department, Dr. Khalid Al-Maghrabi, the associate professor of Assiut University Hospital, and Dr. Tariq, the vice president of the meeting, and he is the associate professor of cardiology as well. Actually, we have a very interesting case today, a high-risk patient with heart failure who is difficult to treat, and this case will be presented by Dr. Noha Gamal, who is the assistant lecturer of Assiut University Hospital. And actually, I would like just to give some points before we start as regarding the scenario of the session. First, the chairman can ask Noha after ending her presentation if they would like to inquire or ask about the case shortly. And then I would like to ask the speakers to highlight some points which is related to the case at the end of their talk, or some recommendations for the case. And we have 3 lectures actually from Dr. Muhammad Al-Ghani, Dr. Magdi, and from Dr. Ahmed Tag. And finally, Dr. Magdi Al-Gohari will wrap up all together as regarding the talks and the presentation as well. So we start with Noha.
Okay, good afternoon. I'd like to thank the organizing committee for this wonderful meeting. Heart failure case scenario, many choices, difficult decision. The case is 60 years old, male patient, manual worker, heavy smoker, diabetic with a glycated hemoglobin 7%, patient known to be hypertensive, well controlled, his blood pressure was 110/70, dyslipidemic with LDL 70 milligram per deciliter, patient with history of chronic renal impairment with estimated GFR 47 milliliter. 2018 had a history of PCI to LAD and LCX with no reported chest pain after. Patient presented with a dyspnea grade 3 to 4, gradual in onset and progressive in its course of 5 days duration. His examination was all were unremarkable apart from pansystolic murmur over the apex. His ECG was sinus rhythm with heart rate 60 beat per minute, narrow complex with a QS in precordial leads. Echo revealed dilated LA and LV with impairment in the LV contractility, segmental motion abnormalities in territory of LAD and LCX, ejection fraction was 35%, impaired diastolic function grade 2 with decreased mitral valve execution and severe mitral regurg central jet, as revealed in this echo collapse. Apical 2, personal long axis and the personal short axis and apical 4 view, segmental variations. So his home medications were, the patient were on Aldacton 25 milligram twice daily, Ramipril 10 milligram once daily, Carvedilol 12.5 milligram twice daily, aspirin 100 milligram, and rosuvastatin 40 milligram with metformin 1000 milligram twice daily. So the diagnosis of our case, left-sided heart failure with reduced ejection fraction, and his medical disorders were coronary artery disease, hypertensive, diabetic with chronic renal impairment. So the patient classified by American Heart Association as stage C. So what's the next step in management of this case? Either pharmacological line or non-pharmacological line or both. This will be illustrated by the next sessions. Okay, thanks.
You finished.
Okay.
So I would like just to ask if there will be any questions from the chairman as regarding this case, or Dr. عادل.
اوكي. اولا طبعا انا بحب اشكر الدكتور حسام والدكتور جوهري لدعوتي للمشاركه في المؤتمر القوي ده. I had very positive feedback من كل اللي شاركوا في المؤتمر في السيشنز اللي فاتت. Congratulations for your efforts. احنا at the same time كان عندنا مؤتمر ال Working Group of Intervention، وده اللي خلاني للاسف ما تابعش قوي الجلسات. انا بحب اشكر طبعا يعني الاستاذ القدير واخويا العزيز ورفيقي الكفاح الدكتور يحيى كشك على وجوده معانا، وبشكر طبعا البانelists، وان شاء الله تبقى سيشن ممتعه. انا بس كنت عايز اسال اذا كانت عمل اي viability study او اي حاجه للانجكشن فراكشن القليل ده.
Yes, after stabilization of medical condition احنا عملنا stress echocardiography and it was negative for ischemia, while mitral regurgitation not improved the same degree pre as post 4/4 severe mitral regurg.
أنا سؤالي هل الviability دلوقتي is an essential part of assessment of ischemic heart disease، ولا وجود ejection fraction low is a sufficient factor for decision to make angio and to see the anatomy؟ فعايز أعرف رأيي إيه دلوقتي clinical evidence with guidelines.
هي by guidelines class 2B indications for detection of ischemia, but this case low ejection fractions وعنده other straight risk factors diabetes وال CKD، ففي element of neuropathies، في والmotion abnormalities في التريتوري LAD L6 it seems not a kinetic territory, it's markedly hypokinetic. In my opinion, according to the situation of the case, I will do a viability study.
Okay.
Can I add something?
Yes.
أولاً طبعاً I'd like طبعاً to thank Professor يحيى كشك، Professor حسام العربي، Professor طارق عبد الحميد، Professor خالد for the kind invitation. طبعاً CardioAssiut ده يعني من المؤتمرات المهمة اللي الواحد بيحرص طبعاً إنه يشارك فيها كل سنة، وunlike طبعاً السنة دي طبعاً مفيش فيس تو فيس ميتنج، فطبعاً يعني سعيد بمشاركتي معاكم النهارده اونلاين او ديجيتال. طبعا بقول congratulations بروفيسور عادل الاتربي for the success of the working group of intervention في الميتنج الانيوال ميتنج. انا الحقيقه كان عندي ظروف عشان كده ما قدرتش احضر يعني، بس شفت طبعا النجاح الكبير للمؤتمر، فبشكر طبعا دكتور عادل.
افتقدناك يا باشا.
ربنا يخليك دكتور عادل، ربنا يخليك. بشكر الدكتور عادل والدكتور احمد مجدي على المجهود الكبير طبعا اللي عملوه. سعيد طبعا بتواجدي مع اخويا وصديقي العزيز الاستاذ الدكتور حمزه قبيل، الاستاذ الدكتور خالد بركه، مش عارف مين تاني معانا عشان ما ننساش حد، بس يعني الحاله فيري انترستنج اللي عرضتها نهى وبرزنتيشن هايل. انا بس كان اول سؤال الكيدني فانكشن، انا ما خدتش بالي الكرياتينين كام كيدني فانكشن؟
الاستيميتد جي اف ار 47 مللتر.
47.
Yes.
Okay. So طبعا I have a presentation regarding the pharmacological treatment. لأن في العيان ده it's very important to optimize his medical treatment first before discussion for any further referral, either for percutaneous mitral valve repair or sending him for bypass surgery, irrespective of the viability, because we know that the long-term stitch trial 10 years proved the good outcome with rehabilitation irrespective of the presence or absence of viability. طبعا ال CMR هو الجولد ستاندرد للاستيميشن الفايبيليتي، not the vitamin stress echoes. CMR is more يعني sensitive and accurate في الاستيميشن of viability in these patients. First we have to give the patients the maximal proper medical treatment, because he is on ACE inhibitor and we can replace ACE inhibitor by ARNI.
Okay.
But in this situation, you have to be very cautiously regarding the kidney function.
Okay.
So still he is a candidate for ARNI instead of ACE inhibitor, and to keep monitoring of creatinine and potassium. And he's also a candidate for SGL2 inhibitor.
Okay.
because you know that this is a new class of drugs which decrease
Class one.
mortality and hospitalization for heart failure. So these two important drugs should be considered before considering these patients as refractory heart failure. I will discuss in details more when I go into my presentation regarding pharmacological treatment. So if you would like to postpone the discussion
Yes, okay.
until the end of the treatment, because it's a pharmacological treatment, my title of presentation, and then I know that there is another presentation, non-pharmacological treatment, which
Yes,
will include
yes.
device therapy, revascularization, etc. So at the end of these two presentations, we can apply the treatment, pharmacological and non-pharmacological, for this interesting case, and go in a discussion and what is the strategy of treatment. If you
المهم
like
اتكلمنا
this-
على الترانزيشن والبايونير والحاجات دي، اتكلمنا طبعا على
احنا مستنيين بقى نشوف. اوكي.
Transition of pioneer. This is not a symposium. This is
اوكي.
transition of pioneer symposium, not a.
ازاي هو ده ايفيدنس الايرلي ستارت اوف
Yes, I know. بس
I would like to welcome Professor Yasser Abdelhadi.
hospitalized patients.
Okay. I would like to welcome Professor Yasser Abdelhadi, who joined us. Professor Yasser Abdelhadi, the head of cardiovascular medicine department in Beni Suef University. Welcome to Yasser.
اهلا دكتور ياسر عبد الهادي. دكتور ياسر.
هو عامل ميوت،
عامل ميوت
عامل
للمايك.
ميوت يا ياسر.
ميوت.
دكتور ياسر ازيك؟
ازي صحة دكتور مجدي دكتور عادل بيه
عامل ايه؟ ما خدتش بالي انت موجود، معلش.
لا هو دخل دلوقتي من شوية. Now we'll move to the first presentation in this session. Will be from Professor Mohammed Abdelghani Karim, Associate Professor of Cardiovascular Medicine in Assiut University, and Vice President of the Working Group of Heart Failure in the Egyptian Society of Cardiology. He will talk about cardiac biomarkers guiding therapy to optimize care.
Thanks, Dr. Hassam. Thanks, all the chairman. My talk will be about the cardiac biomarker guiding therapy to optimize care. Cardiac biomarker have many potential uses in patients with heart failure. They can help in diagnosis. Does this patient have heart failure or something else? They help in risk stratification. Does this patient need hospitalization? Should they be referred for transplant, LVAD, or palliative care? Selection of therapy. What should I do to make this patient better? And also in titration of therapy, should I keep doing what I am doing or should I do something else? Many pathophysiological changes occur during heart failure: volume overload, pressure overload, mechanical stress, ischemia, loss of membrane integrity. All of these pathophysiological changes lead to release of many biomarkers. We will discuss the most important biomarkers: natriuretic peptide, SCT2, high sensitivity troponin, and procalcitonin, and other two important biomarkers. BNP, the most important, is released by ventricle in response to stress or strain. They have many potential beneficial effects in patients with heart failure because they induce balanced vasodilatation, arterial, venous, and in coronary arteries. They decrease aldosterone level, endothelin, and norepinephrine, increase diuresis and natriuresis. According to the last European guidelines 2016, measurement of plasma natriuretic peptide level, either BNP, N-terminal BNP, or MR-pro-ANP, is a class 1 level of evidence A in patients with acute dyspnea and suspected acute heart failure, to help in the differentiation of acute heart failure from non-cardiac cause of acute dyspnea. Also, the American College of Cardiology and American Heart Association recommend measurement of BNP or N-terminal pro-BNP for diagnosis and assessment of severity of chronic heart failure patient. It has 90% negative predictive value and 90% accuracy. But we should think about confounders. Some condition may increase the level of PNB, like pulmonary hypertension, pulmonary embolism, sepsis, acute coronary syndrome, renal insufficiency, and other conditions that may decrease the level of PNB, like obesity, pulmonary edema, cardiomyopathy sometimes cause a raise in the level of PNB. ST2, I think this will be the future biomarker. ST2 is a member of interleukin-1 receptor family. It is found both as transmembranous form as well as soluble form in the serum. It is the receptor for interleukin-31 secreted by living cells in response to cell damage. The interaction of interleukin-33 and ST2 has been proved to be cardioprotective, reducing myocardial fibrosis, cardiomyocytes hypertrophy, apoptosis, and improving myocardial function. This diagram shows the two forms, the serum form and the transmembranous form. It has advantage not affected by age, sex, body mass index, AF, renal function, and anemia. It could predict all-cause mortality and cardiovascular deaths in patients with non-ischemic heart failure. American College and American Heart Association 2017 guidelines recommendation has been categorized it as a marker for myocardial fibrosis for additive risk stratification to natriuretic peptides. It has sharp cut points, 35. More than 35 equal risk. The higher the level of ST2 concentration, the higher the mortality rate. Moreover, ST2 level drawn on admission are highly predictive of future heart failure readmission, one of the most complications of heart failure, and more so than natriuretic peptides can do. Heart failure and infection. Infection presents in 20% of hospitalized patients with acute heart failure. If pneumonia untreated, hospital mortality may reach up to 20% versus 5% in the usual condition. Use of procalcitonin to guide initiation and duration of antibiotic treatment in patients with acute respiratory infection was effective in reducing antibiotic failure. In this nice trial, patch trial, they measure the level of procalcitonin and PNB in patients presenting with acute dyspnea. If the patient has a low level of PNB and low level of procalcitonin, this means the patient has no acute heart failure, no pneumonia. Higher procalcitonin and low level of PNB, this means the dyspnea is due to pneumonia. If both levels are high, so the patient may have heart failure and infection. The European Society of Cardiology Guidelines 2016 stated that assessment of procalcitonin may be considered in patients with acute heart failure with suspecting coexisting infection, particularly for differential diagnosis of pneumonia and to guide antibiotic therapy. High sensitivity troponin is one of the markers of heart failure. Differentiate heart failure from acute coronary syndrome. It is essential in patients with anthracycline cardiomyopathy follow-up. It can differentiate between acute heart failure and acute ischemia, in addition to imaging, clinical situation, and patient presentation. Galactin-3 is another promising biomarker associated with the cumulative development of fibrosis and apoptosis in cardiac remodeling. American College and American Heart Association have given a Class 2B recommendation for measurement of galectin-3 in acute decompensated heart failure, level of evidence A, and chronic heart failure, level of evidence B, for the purpose of risk stratification and the prognosis in patients with heart failure, stage C and D. It identifies specific heart failure phenotypes. Patients with low galectin-3, this means non-remodeling heart failure, relatively they have a good prognosis, likely to be responsive to traditional treatment. Patients with high galectin-3 level, this means remodeling heart failure, relatively poor prognosis, may need earlier referral for advanced heart failure therapy, and they should consider specific anti-remodeling therapy. Gross differentiation factor 15 is a stress response cytokine that is a distant member of transforming growth factor beta family. In cardiomyocytes, gross differentiation 15 factor is produced and released in the setting of oxidative stress or in response to stimulation with cytokine or angiotensin II. It was positively associated with heart failure severity, highest value of N-terminal pro-BNP, and it associated with increased all-cause mortality rate. In conclusion, biomarker in conjunction with clinical and physiological assessment can provide greater diagnostic accuracy than physical assessment alone. The natriuretic peptides are the best established and best evaluated marker to help in the proper diagnosis and exclusion of heart failure. ST2, high sensitivity troponin, procalcitonin will likely soon join natriuretic peptide as a biomarker routinely measured in heart failure patients in various settings. And thank you.
In this case, Mohammed, what do you think that we should do for this case?
العيانة دي طبعا هي already diagnosed as a heart failure, so we don't need diagnosis. We need stratification, risk stratification. I think galectin-3 and ST2 will be beneficial in risk stratification of this patient to determine if we will need device therapy or further advanced treatment of heart failure.
Thank you, Mohammed, for your excellent presentation. But I didn't get actually from your title how biomarkers guide for therapy. This is one, and the second I gathered from the GUIDE-IT trial that biomarker-guided therapy is not still well established. So it didn't give positive results for some trials, and so it is still controversial.
Yes. As you said, Dr. Yahya, it is biomarker-guided therapy is not well established yet, but it helps in stratification. So I decide what's the best treatment for the patient. But if I measure the level of biomarker, does not determine the dose of drugs, just risk stratification.
Does not affect the choice.
No.
The standard therapy is well known according to the guidelines and will not be affected by the results of the biomarkers regarding risk stratification.
Not yet.
بنرحب بدكتور مصطفى مقرب دخل معانا.
I think I would just like to add some comment.
دكتور خالد بركة تفضل.
Okay. Probably the biomarker use is not well established and it will not affect the treatment, but I will say that procalcitonin is an exception because it added some new information about the coexistence of infection. So it's actually a very good biomarker used to control whether you have infection or not, whether your antibiotic therapy is effective or not, whether you are controlling the infection and going in the right way, or the infection is still uncontrolled and you need to modify your antibiotic regimen, and so on. So I believe this is a well-established biomarker, and it helps much in the treatment of our patients, not only those with heart failure, but those with infective endocarditis, for example.
شكرا دكتور خالد.
ممكن
دكتور عادل اتفضل.
هو يعني معروف ان الان تي برو ان بي كان بي يوزد مش بس للدايجنوزس، كمان تو ميجر ذا ريسبونس تو تريتمنت. والحقيقه الان تي برو ان بي متوفر ومش غالي.
هو فعلا الوحيد اللي في الجايد لاينز.
واحنا ابتدينا نستخدمه. انا سؤالي بقى لمحمد، وانا بشكره على المحاضره الرائعه دي.
شكرا يا باشا. شكرا
على الاس تي 2 انت بتقول اكتر من 35 از دايجنوستيك. طيب هل في ارقام ان ريسبونس تو تريتمنت، يعني مثلا زي الان تي برو ان بي كده؟
لا لسه يا باشا،
لسه. يعني لسه. هو مجرد
بروجنوستيك ماركر،
ماركر كده للريسك، لكن مش هنقدر نستخدمه كريسبونس للتريتمنت، مش كده؟
ايوه يا فندم. هو مش موجود في مصر برضه، مشكلته مش
دكتور مجدي
موجوده، ما اعرفش.
دكتور مجدي عبد الحميد.
presentation, but I want to ask about the role of the new biomarkers like procalcitonin or ST2 as regarding acute or chronic heart failure, or in the if there is different parameter cut-off points like the ProPNP or PNP.
Cut points, sharp cut points for treatment, not, but there are cut points for diagnosis and assessment of the risk.
I'd like to add something. Thank you, Dr. Muhammad, for your elegant presentation.
Thanks, Dr. Magdi.
Of course, natriuretic peptides have an important role in diagnosis, prognosis, and sometimes to guide therapy, but the results are contradictory. Some trials prove the efficacy of guideline-directed therapy followed by NT-proBNP, and the others prove that standard occur the same, except in patients less than 75 years of age. So regarding procalcitonin, it has no role in heart failure at all. Procalcitonin, it's an inflammatory marker which can diagnose pneumonia and chest infection, of course, but in the and it can be used in sometimes to differentiate whether patients presenting to the emergency department with acute shortness of breath, whether this is chest problem, acute pneumonia, or heart failure. You can do procalcitonin, but NT-proBNP, if it's available, will be the gold standard for diagnosis of heart failure. So procalcitonin is not in the guidelines regarding heart failure, either for diagnosis or for risk stratification. ST2 protein, a good marker, but it's a marker which related to the remodeling, fibrosis, and it's prognostic, not a diagnostic, but it's in the clinical practice, not yet applied, and the guidelines do not include ST2 protein. So it is in the research only, ST2 protein not yet approved in the guidelines.
اوكي شكرا دكتور مجدي. شكرا دكتور محمد.
شكرا.
It's my pleasure to introduce Professor Magdi Abdelhamid for the second lecture about pharmacological treatment for heart failure, a major leap.
Thank you very much, Professor Khalid, for the kind introduction. Again, I'd like to thank all the staff members at the cardiology department at CUT University for the kind invitation, and congratulations for a successful meeting as usual. Thank you very much, Professor Hussam Hassan, the chairman of the cardiology department. Thank you very much, Professor Yahya Kishk, and all my colleagues at the cardiology department. So in a couple of minutes, I'm going to cover pharmacological management of HFrEF, heart failure with reduced ejection fraction, and this slide summarizes the compensatory mechanisms in patients with heart failure. Once those patients develop myocardial damage due to myocardial infarction, myocarditis, cardiotoxicity, or any other etiology, we know that there is a neurohormonal activation of the renin-angiotensin-aldosterone system, sympathetic system, arginine vasopressin, endothelin system. At the end, we have salt water retention, which increase preload ventricular filling pressure, and this will be responsible for symptoms and signs of congestion. And at the same time, peripheral vasoconstriction due to increased angiotensin II and sympathetic system will lead to increased systemic vascular resistance, which will lead to decrease the forward stroke volume and the cardiac output, and the vicious cycle will continue. So we have to tackle all these bad new hormonal system. And we know, according to 2016 guidelines, and heart failure has three phenotypes. HFrEF, symptoms and signs of heart failure with ejection fraction less than 40%. HFpEF, symptoms and signs of heart failure, ejection fraction 50% or more, with elevated levels of natriuretic peptides and at least one additional criteria, which is a relevant structural heart disease and evidence of diastolic dysfunction. And the new phenotype, which is mid-range and ejection fraction 40 to 50 to 49% with the same criteria of HFpEF. So the aim of treatment is to improve symptoms and quality of life, to prolong survival, and to decrease hospitalization. Because the main burden for heart failure patients are recurrent hospitalization and the poor outcome. We know that the mortality rate 5 years from diagnosis of heart failure is around 50%. So this slide summarizes the different targets which should be tackled to improve the outcome of patients with heart failure. The renin-angiotensin-aldosterone system can be blocked with the use of ACE inhibitor, ARBs, ARNI, aldosterone antagonist, sympathetic nervous system by the use of beta blockers, and to preserve the endogenous natriuretic peptides and the vasodilator materials, we can use ARNI, which is cyclopentine valsartan added to angiotensin receptor blocker. And the increased heart rate is detrimental in patients with heart failure. So we need to slow the heart rate by the use of beta blockers or ivabradine. And for patients who cannot be given ACE or ARBs, and in African American population, the combination of vasodilation and oxidative stress modulation by using a hydralazine isorbitadienitrate combination is a good strategy for those patients. And arrhythmic sudden death is common in heart failures, around 50%. And this can be prevented primary or secondary by the use of ICD. And in patients who have electrical and or mechanical dysynchrony, the use of cardiac resynchronization or CRT therapy can improve the outcome because it improves symptoms, quality of life, and decrease mitral regurgitation and decrease mortality. And the congestion can be treated with the use of diuretics, and the reduced exercise capacity can be managed with exercise training and cardiac rehabilitation in compensated patients. So let us to give a look for these drugs individually. If we look for diuretics, the key points that they relieve symptoms of congestion, but unfortunately, they activate the sympathetic nervous system and the renin-angiotensin-aldosterone system. So we have to use a flexible diuretic strategy, the lowest dose which relieve congestion and maintain evolemia. So we know that diuretics have no impact on mortality. It relieves congestion only, and diuretic resistance is commonly seen in patients with heart failure, especially in advanced heart failure, due to poor oral bioavailability of the drug, compensatory distal tubular cellular hypertrophy, which is responsible for increased sodium reabsorption, and renal insufficiency, which is present in 40 to 50% of patients with heart failure. Thiazides and aldosterone antagonists should be given before loop diuretics, and don't forget concomitant sodium restriction. And we know that ACE inhibitor, beta blocker, MRA are considered life-saving pharmacotherapy and +1 year recommendation according to the guidelines, because according to many trials used ASR or ARBs, beta blockers, MRA, it decreased mortality as well as reduced hospitalization. And this slide shows the beneficial effect for using ACE inhibitor, ARBs reduction, relative risk reduction mortality with the use of candesartan in the SHARM low ejection fraction by 12%, and the INSOLVIT trial with the enalapril at 16% relative risk reduction mortality, and CEBIS-2 merit heart failure Copernicus, the use of beta blockers was associated with 34% relative risk reduction mortality, and the RALS study using spironolactone or emphasis heart failure using eplerenone was associated with a relative risk reduction mortality 30%. So regarding the use of ACE inhibitors in heart failure, it improves symptoms, clinical status, exercise capacity, improve cardiac function, reduce hospitalization, attenuate remodeling, prolong survival, and reduce vascular events. So in the daily practice, those drugs should be used in all heart failure patients with an EF less than 40% and all NIHA classes. And we have to use the target dose which used in clinical trials. And the intolerance due to cardiorenal limitations is associated with poor outcome. ACE inhibitor can be responsible for cough, angioedema, or anemia, and we have to expect some rise in creatinine, up to 30% increase in creatinine after the use of ACE inhibitor. And the most studies excluded patients with creatinine more than 2.5 milligram per deciliter. The rationale for using beta blockers in heart failure, we know that heart failure is associated with increased sympathetic nervous system activity, and the deleterious effects of catecholamine stimulation. It increased myocardial oxygen demand and ischemia, it increased oxidative stress, accelerate remodeling, lower threshold for ventricular arrhythmias, and it has toxic effect on the myocytes regarding necrosis, apoptosis, and long use of beta blockers will be associated with downregulation of beta-1 receptors in heart failure. Heart failure is associated with downregulation of beta-1 receptors. So we have to expect the benefit of beta blockers in heart failure. It can lead to upregulation of beta receptors in the myocytes, decreased myocardial oxygen requirements. It has an anti-arrhythmic effect. Slowing the heart rate will improve myocardial relaxation, protection against fatal arrhythmias, and the correct renin-angiotensin system overactivation, and reduction in incidence of acute coronary events. And this slide summarizes the different beta blocker trials in heart failure and the significant reduction in mortality using beta blockers in CEBIS-2, bisoprolol, metoprolol in merit heart failure, and carvedilol in Copernicus trial. So in the clinical practice, it's indicated for symptomatic or asymptomatic heart failure ejection fraction less than 40%. We have to start low and go slow. So you have to use the agents which are used in clinical trials and initiated when the patient is dry and off intravenous vasoactive agents and prior to hospital discharge. Titration every 2 to 4 weeks as long as the patient is stable, no bradycardia, no hypotension, and adjust other medications if the patient develops dyspnea, hypotension, or weight gain. And usually in acute decompensated heart failure can be treated without changing the beta blocker dose. MRA or mineralocorticoid receptor antagonist should be considered in most patients with heart failure with an EF less than 40%. You have to keep eyes on serum potassium and creatinine, and contraindicated if the patient has serum potassium level more than 5, creatinine more than 2.5 milligram per deciliter, and be cautiously in elderly diabetic patients or patients using non-steroidal anti-inflammatory drugs. Post-MI, eplerenone is preferred over spironolactone. Now we have ARNI, which is sacubitril/valsartan, and the rationale for using this drug is neprilysin inhibition to decrease the degradation of the endogenous natriuretic peptides and the vasoactive peptides, like atrial natriuretic peptide, the DNP, substance P, bradykinin, adrenaline, which has a vasodilator effect, decreased blood pressure, decreased sympathetic tone, decreased aldosterone, fibrosis, hypertrophy, and it has natriuretic and diuretic effect. Neprilysin also is responsible for degradation of angiotensin II. So we have to use angiotensin receptor blocker, valsartan, to block the AT1 receptors to avoid the detrimental effect of angiotensin II at the AT1 receptors, which induce vasoconstriction, increased blood pressure, increased sympathetic activity, increased aldosterone, fibrosis, and hypertrophy. So this is the rationale for ARNI or sacubitril/valsartan and the active component responsible for neprilysin inhibition is LPQ657. So we know the landmark trial, paradigm heart failure trial, which included more than 8,000 patients with heart failure, function class 2 to 4. And after a single blind run-in period, compared to the standard of care or the cornerstone of treatment, ACE inhibitor enalapril, 10 milligram PID, and titration of the drug every 2 to 4 weeks up to 200 milligram PID secondary valsartan. Patients randomized to ARNI versus enalapril, and study was symptoms driven and prematurely terminated after 27 months due to the overwhelming benefit of secondary valsartan in terms of reduction of the primary endpoint, which was cardiovascular death or heart failure hospitalization. So this slide shows the compared to enalapril, the use of sacubitril valsartan was associated with statistically significant reduction of the composite endpoint, cardiovascular death or heart failure hospitalization by 20%, and the number needed to treat was 21 patients. And if we look for cardiovascular death, statistically significant reduction, 20%, and number needed to treat was 32 patients, 32. And all-cause mortality decreased significantly by 16% with the use of sacubitril valsartan compared with enalapril. And interestingly, the use of sacubitril valsartan was associated with significant reduction in mortality, all-cause mortality, cardiovascular death, sudden cardiac death, or death due to worsening of heart failure. So according to this impressive data, the guidelines recommended the use of sacubitril valsartan in patients with heart failure as a replacement for ACE or ARBs to further reduce the risk of heart failure hospitalization and death in ambulatory patients with HFrEF remain symptomatic despite optimal treatment with ACE inhibitor, beta blocker, and MRA class 1B recommendation. If the patient has a heart rate more than 70 beats per minute, heart rate slowing is important because it reduces myocardial oxygen consumption, improve contractile performance, improve diastolic filling, reduce risk of VF and sudden death, and it promotes reverse remodeling. So IF current inhibitor, which is ivabradine acting specifically on the SE node, have been associated with significant reduction in the combined endpoint of mortality and cardiovascular hospitalization for heart failure by 18% in SHIFT trial. So the guidelines recommended ivabradine class 2A recommendations in addition to beta blocker if the heart rate more than 70 beats per minute, despite treatment with an evidence-based dose of beta blocker or maximum tolerated dose of beta blocker. And in patients who are contraindicated to receive beta blockers or cannot tolerate any doses of beta blockers, ivabradine is a good drug to slow the heart rate and class 2A recommendation. So this slide summarizes the algorithm for treatment of patients with heart failure according to 2016 guidelines, that patients with symptomatic HFrEF should be given diuretics if they are congested to relieve symptoms and signs of congestion. Therapy with ACE inhibitor and beta blockers to decrease mortality and hospitalization, up titration to maximum tolerated doses. And if the patients are still symptomatic with an EF less than 35%, add MRA, and you have to monitor serum potassium level to avoid hyperkalemia. If the patient is still symptomatic with an EF less than 35% and have an evidence of electrical and or mechanical dysynchronous QRS complex for more than 130 milliseconds, you have to consider CRT. Patients able to tolerate ACE and ARBs replaced by ARNI, heart rate more than 70, is a candidate for ivabradine. And in patients with persistent symptoms, consider digoxin, hydrazine isorbide dinitrate combination, LVAD, or heart transplantation. And don't forget primary and secondary prevention of sudden death by implanting ICD for patients who have an EF less than 35%, despite optimal medical treatment or history of symptomatic VT and ventricular fibrillation. Recently, we have a very interesting group of drugs, which is sodium glucose cotransporter, which decreased the sodium glucose cotransporter pathway in the proximal renal tubules. And this will result in natriuresis increase the urinary and glucose and water loss. So the mechanisms of action of this drug, in addition to natriuresis, it decreased the preload and afterload and the reduction alveolar stress, reduction in interstitial edema, and improved kidney function and the cardiorenal physiology. And this is an example for one of the important trials, which is DABA-HF trial, included more than 4,000 patients who have symptomatic heart failure, ejection fraction less than 40%, high levels of NT-proBNP, the rationale that dapagliflozin will be superior to placebo added to standard of care in patients with symptomatic chronic heart failure with reduced ejection fraction, with and without type 2 diabetes, looking for cardiovascular death and worsening of heart failure or urgent heart failure visit. So the primary endpoint using dapagliflozin compared with the standard of care was associated with statistically significant reduction in the primary endpoint, cardiovascular death or heart failure hospitalization or an urgent heart failure visit. And the worsening of heart failure event was statistically significantly lower compared with placebo, and the earlier benefit of the drug within the first 2 months indicates the hemodynamic benefit of the drug regarding preload reduction and the reduction of heart failure hospitalization. Again, this slide shows the cardiovascular death reduction. It was also statistically significant with the use of dapagliflozin. And interestingly, the benefit of the using dapagliflozin compared to placebo was proved either the patient is diabetic or non-diabetic, because 40 to 50% of patients only are diabetic in this trial. So again, the second endpoints, cardiovascular death or heart failure hospitalization, significantly lower with the use of dapagliflozin. And also we have impero reduced trial using empagliflozin to investigate the safety and the efficacy of empagliflozin versus placebo on top of guideline-directed therapy in patients with HFrEF study, which included more than 3,700 patients type 2 diabetes and non-type 2 diabetes, chronic heart failure function class 2 to 4, and they have an EF less than 40%. Empagliflozin in a dose of 10 milligram per day plus standard of care compared with the placebo and standard of care, look for the primary endpoint, cardiovascular death and the adjudicated heart failure hospitalization. Also, the use of empagliflozin was associated with the same benefit in patients with heart failure regarding reduction in cardiovascular death or hospitalization for heart failure, a relative risk reduction of 25%, absolute risk reduction of 5.2%. So now, in addition to the guideline-directed medical therapy, which is ARNI, psychometric valsartan, ACE or ARBs, MRA, beta blockers, we have a new group of drugs, which is sodium glucose cotransporter inhibitor, and this group of drugs, according to the two important trials, impero reduce and DABA-HF, I think they are game-changing class in the treatment of heart failure, and you will see the updates in the recent guidelines 2021 to be included in addition to the guideline-directed medical therapy. Thank you for your attention.
Thank you very much, Dr. Magdi, for this comprehensive lecture. You managed actually to competently elaborate on different pharmacological aspects in such a short time. Congratulations, sir. I ask the panelists if there are any questions.
Yes, please, can I ask Professor Magdi two questions, two short questions?
Yes.
The first one about the role of ARNI in preserved ejection fraction. Second one, which you would choose, empagliflozin or dapagliflozin as a better prognosis for your patient?
Okay, thank you very much, Professor Hamza. Regarding the heart failure with preserved ejection fraction, we know the outcome of Paragon heart failure trial, that although there was a significant reduction in hospitalization, however, there is no impact on mortality, so the primary endpoint was not statistically significant. However, sub-analysis of Paragon heart failure trial proved the benefit for an ejection fraction above 50%, 57%. And in addition, the benefit was proved in women compared with men. You know that heart failure with preserved ejection fraction is a heterogeneous disease. A lot of phenotypes, a lot of comorbidities. So until now, we don't have a drug which proved to decrease mortality, and we don't have a guideline therapy in HFpEF. In addition to, we know that the treatment is diuretics, treatment of hypertension, treatment of diabetes, manage ischemia, control heart rate. So we cannot say that sacubitril valsartan or ARNI until now in HFpEF was beneficial according to the Paragon heart failure trial. The second question, DABA and Emperor, both are positive outcome trials. You can use DABA, you can use Emperor. The two trials are complementary and the results are concordant. And if we look for Emperor, ejection fraction 27, DABA 31, GFR in Emperor up to 20, the cutoff level to be used. In DABA, the cutoff level for ejection fraction was 30. And these drugs should be used in addition to guideline-directed therapy after using ACE or ARBs or ARNI, MRA, and beta blocker. So both drugs are good. Both drugs prove to decrease the primary endpoint, and both drugs was associated with renal protection. If we look for the renal outcome for EMBA, 50% reduction in the primary renal endpoint, the need for dialysis, the need for transplantation, renal death, significantly lower with empagliflozin in Emperor reduced. So both can be used in patients with heart failure.
أشكرك بروفيسور ماجد، أشكرك جزيلا على
I have a question, please, Dr. Hussam. Can I ask Professor Dr. Magdi? First, I would like to thank him for this very excellent presentation as usual. And I want to ask him about the vericiguat, the new agent in the Victoria trial, just published in the New England Journal of Medicine in May 2020. The new guanylate cyclase stimulator, the same mechanism like vericiguat used in group 1 pulmonary hypertension and also the group 4 pulmonary hypertension. This trial on 5,000 patients and proved to reduce the hospitalization and also morbidity and mortality. Do you think, Dr. Magdi, that this drug will be included in the new guidelines in 2021 heart failure?
Thank you very much, Professor Yasser. Excellent question. Vericiguat is a good drug. It is, as you mentioned, the soluble guanylate cyclase agonist, which increases nitric oxide. And the Victoria trial proved the efficacy and safety of using this drug in decreasing the primary endpoint, mortality, and heart failure hospitalization. But this drug was reserved for patients who have worsening heart failure, function class 4, not like SGLT2 inhibitor trials or ARNI 2 to 4. If you look for the inclusion criteria in Victoria trial, those patients have very high levels of NT-proBNP level, patients who have recurrent hospitalization or recently using intravenous inotropes. So these drugs will be considered for advanced heart failure, recurrent hospitalization, worsening heart failure patients, not in patients with function class 2 to 4. Function class 2 or 4.
ممكن اقول حاجه يا دكتور يحيى؟ انا بس يعني كان نفسي وعايز اعرف تعليق الدكتور مجدي. انا هقول my suggestions for this case. انا كان نفسي الكيس اللي اتعرضت نعمل ريفليكشن للادويه دي على الكيس دي بالذات وازاي هنتصرف معاها ابارت بقى من الفيرذر مانجمنت. فانا اقتراحاتي وعايز راي الدكتور مجدي ان انا طبعا لا يصح في العيان ده ما اديش SGL2 لحاجتين، الهارت فيلير والرينال بروتكشن. دي نمره واحد. نمره اثنين ان الايفيدنس دلوقتي with early start of neprilysin inhibitor اللي هو sacubitril valsartan because مش هنستنى بقى شهر على ايس او ARB ونغير ولو tolerated. الكلام دلوقتي بيتغير، فاعتقد الحاله دي برضو شيفتنج لو البريشر يسمح ولو العيان مش على دايوريتك او فينوتروبس، وهنشوف الهارت ريت ونطبق ده. فانا عايز اعرف تعليقك على العيانه دي بالذات يعني.
طيب
عايز اعرف انت هتعمل ايه.
ده very interesting question بروفيسور عادل.
مجدي برضه في نقطة خلي بال حضرتك ان الاي جي اف ار 42 في العيان 47.
اوكي، اول حاجة these patients I will replace ramipril 10 mg by cyclosporine valsartan 50 mg twice, and I will stop the MRA. 50 mg is too high for these patients now. To monitor the serum potassium to avoid the risk of hyperkalemia in patients with CKD. So I will stop ramipril, I will stop MRA, I will start ARNI 50 mg twice per day. I will follow up the serum creatinine, GFR, and serum potassium. And if the patient's responding well and no congestion, not congested, I will decrease the dose of diuretics. This is very important. And titration of cyclosporine valsartan is very important because the evidence regarding the improvement, especially in ejection fraction, is with the highest dose, not with the lowest dose. So we have to titrate every 2 weeks from 50 to 100, 100 to 200 if the serum creatinine and potassium allows. Patient has no hypotension, no more rise in creatinine, no more rise in potassium. But if the patients responded initially to 50 and I couldn't titrate to more high dose, it's okay. I will keep her on 50 mg twice per day. Diuretics is flexible according to symptoms and signs of congestion. And then I can add MRA starting by small dose. I can start by 12.5 up titrate to 25 if there is no hyperkalemia. Now the heart rate is 60, so I will not add ivabradine. I will keep the same dose of beta blocker, which is carbidopa, 12.5 twice. This is good. Now the question regarding the mitral regurgitation. There is an evidence that guideline directed medical therapy can decrease mitral regurgitation because these drugs improve reverse remodeling with the use of cyclosporine valsartan. It has a favorable effect in remodeling and it can decrease mitral regurgitation. And there is many studies which prove the significant reduction in mitral regurgitation with the use of cyclosporine valsartan.
هتستنى قد ايه بقى؟ هتستنى قد ايه لغايه لما تشوف الريسبونس بتاع الميترال؟
It will not be before 3 months at least. 3 to 6 months, not before that. So if there is a significant reduction in mitral regurgitation, that's fine. If there is no response, mitral regurgitation is still severe, and the pulmonary artery pressure is high, and the patient's symptomatic function class 3, for example, then I will look for the feasibility of transcatheter mitral valve repair. We have a good data from the COAPT trial, as you know. MITRA FR and COAPT. MITRA is European study, COAPT is American study, and the good outcome regarding the primary endpoint, which was hospitalization for heart failure or death from cardiovascular causes and hospitalization for heart failure in MITRA FR, the COAPT was positive compared with MITRA FR. MITRA FR was negative, but COAPT was positive, but it was explained by regarding the better technique, regarding the optimal medications in COAPT compared with MITRA FR, regarding the ventricle was smaller in COAPT compared with MITRA FR, and the more mitral regurgitation and the end-diastolic volume was lower in COAPT compared with MITRA FR. So there is a controversy about the transcatheter mitral valve repair, but it should be considered. It's class 2B recommendation in the guidelines until now, and it will be considered if you using the guideline direct medical therapy for maximum target doses and the patient still symptomatic, mainly due to mitral regurgitation. I will consider the possibility of transcatheter mitral valve repair.
طارق، رأيك ايه يا طارق؟
السلام عليكم. I approve what Professor Magdi has said. Actually, a combination of pharmacological and non-pharmacological approach is very important in such cases. We shouldn't just stick to the pharmacological line and forget about correcting structural problems that will maintain the patient's symptomatology and the progressive cardiac deterioration. So along with the pharmacological adjustment, we have to also put in mind that non-pharmacological approaches, starting from percutaneous interventions and up to advanced surgical interventions, are very important to keep in mind.
طبعا the possibility of total revascularization should be considered a heart team approach and CMR, and then discussion for the benefit of doing total revascularization if the patient is candidate for total revascularization.
هو دكتور احمد تاج بقى هيكلمنا عن نون فارماكولوجيكال اعتقد.
Dr. Magdi, thank you for your excellent presentation and comments as well.
Thank you very much, Professor Yahya.
What about the heart failure risk score assessment? This is one. And the second, بصفة حضرتك بقى رئيس ال working group of heart failure, is there an Egyptian guidelines for heart failure in the near future? لأن زي ما حضرتك شفت كده في a lot of controversies and in the presence of new investigations and new treatment. So we have in Egypt actually guidelines for this.
Regarding the second question, هو احنا we have registry انما guidelines احنا usually we follow the European guidelines, but we can do وده ان شاء الله بعد ال new heart failure guidelines next year 2021 we can do a consensus for heart failure management in the era of new drugs for heart failure. We have SGLT2 inhibitors, ARNI, CardioAssiut, so we can do a consensus, not the guidelines, because you know that the guidelines are based on trials, based on major trials, and in Egypt we follow the European guidelines. But
لسه الأوميكامتيف يا مجدي اللي هو مايوسين اكتيفيتور.
Galactic heart failure study have been published, and it is a omecamtiv mecarbil. It is cardiac myosin activator, and it has a positive inotropic effect. It is not associated with increased heart rate or myocardial oxygen consumption, and the outcome of Galactic heart failure trial also is significant reduction.
شكله هيعمل حاجة ده.
Yes, and Servier is investing in this drug, omecamtiv mecarbil.
Many thanks, Professor Magdi. I was suggesting adding ARNI for this case and replacing for ramipril, as you said. My question to you: follow-up EGFR and creatinine clearance, the timing interval between the follow-ups every 2 weeks or every 1 month. This is the first question. The second one, what if the patient developed end-stage renal disease with very low creatinine clearance?
Two difficult questions, dear Khaled.
متشائم خير.
The first question in patients with CKD with a baseline reduced kidney function and low GFR, the monitoring should not be as routine, because in patients without CKD, we are following the serum creatinine and the potassium 1 week after the initiation, then after 2 weeks, 3 months, according to the rise of creatinine and the potassium. But in patients with CKD, you have to very cautiously, because hyperkalemia can be lethal for this killer for this patient. So you have to monitor potassium and creatinine very closely, 48 hours after initiating, then every week until you are sure that there is no more rise of creatinine and potassium with the dose of 50 milligram which you started with. And if the patients developed end-stage renal disease, we can use ARNI, by the way. It was mentioned that you can use it up to 15 milligram, up to 15 milli per minute, GFR. But in my daily practice, for me, it's up to 30, not 15. I'm not using it below 30. But if the patient develop end-stage renal disease, of course, you will stop the medication and you will be treated as heart failure with comorbidity, with CKD, with dialysis. And in such cases, you have the non-pharmacological options will be more in favor to be used. In addition to hydralazine isorbide nitrate combination can be used instead of ACE and ARBs.
Thank you, Dr.
I'm asking
Magdi.
this question because the heart failure patient can go okay, except if he started the development of renal failure. The start of getting, of being a chronic renal failure patient or renal impairment, it is the start to the hell.
And the prognosis is very bad once the patients develop end-stage renal failure.
Thank you. We will move to our next speaker, tackling the non-pharmacological treatment of heart failure, recent updates by Dr. Ahmed Taig from Swiss Canal University.
Okay, Bismillah ar-Rahman ar-Rahim. I'd like to thank Professor Hussam Hassan, Professor and Chairman of Cardiology Department at CUT University, for inviting me to attend CardioAssiut virtually, which is annual meeting with fruitful discussions and important topics in cardiology. My topic is about non-pharmacological treatment in heart failure, recent updates. Thank you again for inviting me for CardioAssiut, and I wish you a very successful meeting. And I'd like to invite you all in Ismailia by next March for our Ismailia Cardiometabolic Syndrome Association annual meeting. This will be third one with international edition. Some invited guest faculties from all over the world will be attending this meeting. So we hope to see you face to face and not virtually in Ismailia very soon. According to Socrates, you don't see what you don't know. And by another word, you don't see by your eyes what you don't know by your mind. So we have to know first, so we can judge and see. Heart failure is a growing epidemic with a prevalence of 2% worldwide, increasing up to maybe 20% in patients above age of 70. It's one of the leading causes of mortality and morbidity worldwide. The growing epidemic of heart failure is due to multi-factors: aging population, improved survival post-MI, and increasing prevalence of comorbidities. The ugly face of heart failure, more than 21 millions, according to 2015 data, from heart failure. Economic burden is relatively high, more than $110 billion in USA alone yearly for heart failure supportive care. Mortality is over 50% within 5 years from diagnosis. Number one cause of hospitalization and rehospitalization worldwide, and number one in having multiple comorbidities of more than 3 comorbidities. Pathophysiology of heart failure, regardless the true etiology of ischemia, hypertension, valvular heart disease, postpartum, or any other causes of heart failure, it will end up with ATP depletion, ischemia, and oxidative stress, which leads to myocytes, decreased contractility, impairment of basement membrane, neurohormonal activation of renin-angiotensin system activation, and autonomic nervous system activation as well, and molecular changes, decreased calcium handling, abnormalities in beta receptors, and EDP, which end up with functional changes in the form of decreased cardiac output and ejection fraction, and structural changes in the form of markedly dilated left ventricle. Stages of heart failure and its management implications. This a diagram adopted from Japanese Society of Cardiology, and this is stage A, B up to D according to the American College of Cardiology classification of heart failure. And you can realize that sometimes risk of heart failure is there without symptoms, especially in stage A and in stage B, while in C and D symptoms develops and structural changes is already taking place with onset of symptoms and then resistance to treatment, especially in stage D heart failure. At the same time, you might have those risk factors leading to heart failure in the form of elevator modeling, decreased left ventricular ejection fraction, and then multiple hospitalization, which lead to death. So for stages C and D, medical treatment is important, of course, and we have different NIHA class from NIHA class 1 up to NIHA class 4, either ambulatory or on inotropes. And then we'll have inter-max classification, and this classification aims to differentiate who will benefit from supportive circulatory devices or maneuvers, including even transplantation or surgical options in patients with heart failure. Guidelines, good medical treatment or directed medical treatment is all over those stages. CRT is indicated from stage 2 to stage 4, mainly stage 3 and stage 4, of course. Mitral clep for functional mitral regurgitation is indicated in class 3 and class 4. And then implantable left ventricular assisted devices or temporary mechanical circulatory support is indicated mainly in stage D. So these are the standard medications approved for heart failure, and this is outside our topic of discussion, but you can realize that according to the European and Japanese societies of cardiology, SGLT2 inhibitors are there as class 2A, and they in the very near future will be class 1B, according to John McMurray in one of our meetings with him. He said that it will go for the level of 1, either A or B. Of course, there are other medications which improve cardiac function in patients with heart failure, especially if patients are decompensated, as loop diuretics, MRA, and dopamine, butamine, and norepinephrine. So what about the non-pharmacological treatment in heart failure? And this is our prime topic for this presentation. Firstly, we have to realize whether there is any evidence that the patient is already on the optimal medical treatment and they are still not feeling well, which means 6-minute walking test less than 300 meters, frequent admissions due to heart failure, more than 2 admissions per year, decreased oxygen saturation, worsening right-sided heart failure, and so many other parameters, including hypotension, which is associated with increased mortality. So this is how to detect that the patient is in need for non-pharmacological treatment. So let's start with compliance. We have to health educate all patients with heart failure that they should comply to the instructions and the medications prescribed for them. Diet, we should ensure general nutrition, especially in obese persons, diabetic persons. Salt is advised to be restricted, especially high salt contained foods, and not to add salt on food. Fluids, we have to urge overloaded patients to restrict fluids. Alcohol subsistence, smoking cessation, regular exercise, which is very important, and vaccination against pneumococcal vaccination, influenza, and maybe for the next year against COVID-19. And actually commonly consumed processed foods, you can realize here many of our patients of heart failure might take this, so we have to instead advise them for fresh products like fruits, vegetables, eggs, because they contain less salt content. This card is very important, and all over the EU, especially in the UK, all patients they have this heart failure card, which they can, patients themselves, heart failure nurse or heart failure consultant could write down the pulse, blood pressure, important vital signs, and important biochemical profile, especially patient weight as well, for frequent visits. This card is very important and very simple as well. How a patient could help himself or herself. Self-management of diuretics. Sometimes we can advise some patients who are well educated and can judge clearly that they are overloaded or not, that they can increase the dose of diuretics. Regular exercise, and we'll come to that in a few minutes. Compliance with medication, which is very important, and daily weighting. The patient should weigh themselves and restrict salty and fluid overload in this food. This is the list of non-pharmacological therapy for heart failure, starting with CRT-P or CRT-D device, especially in heart failure patients with wide QRS complex, pulmonary vein isolation for patients with resistant AF not responding to medical treatment, LV plus T, especially in idiopathic cardiomyopathy, especially with left ventricular aneurysm, aortic valve replacement, especially percutaneous in severe AS, mitral valve repair, especially mitral clip in patients with severe degenerative or functional MR, cardiac rehabilitation for all patients, interatrial septal device, especially for patients with heart failure with preserved ejection fraction and elevated pulmonary artery wedge pressure, CPAP, which is some sort of oxygen support for patients with acute pulmonary edema and in some patients with congestion, home monitoring in some patients, temporary mechanical circulatory support in some patients, especially with cardiogenic shock, durable mechanical circulatory support like LVAD in patients who are awaiting transplantation, which is the final stage of non-pharmacological management of heart failure. Some patients will still benefit from cardiac rejuvenation therapy, which is still in infancy period all over the world. What is the role of surgery in heart failure? Some patients will need coronary artery bypass graft or PCI, especially who having unstable angina, reversible ischemia. Some patients will need valve replacement, especially aortic stenosis or mitral regurg. Either replacement or repair, percutaneous repair is available for mitral regurg and aortic stenosis. Permanent pacemakers and implantable cardiac defibrillators and CRT-D in certain patients. Cardiac transplantation in end-stage heart failure. Ventricular-assisted device as short-term or sometimes a bit long-term for who are awaiting transplantation, and some novel surgical techniques in limited places with good experience in this. So these are the intervention approaches, including cardiac resynchronization therapy, percutaneous treatment of secondary mitral regurg, transcatheter aortic valve replacement, AF ablation, ablation of ventricular tachyarrhythmia, including VT and BVCs, and in some patients VF, resuscitated from sudden cardiac arrest, extracorporeal artery filtration, hemodialysis, ventricular-assisted device, and cardiac or heart transplantation. So here are some selected non-pharmacological treatment modalities, and I'll start with exercise because it's the easiest one that needs only will from the patient. The patient has a will to do something for himself or herself. So improvement in exercise tolerance, improvement in quality of life, and improvement even in prognosis. And this is by frequent exercising. It leads to important positive changes in the lung, including improved ventilation, imbalance between sympathetic and parasympathetic nervous system, decreased inflammatory cytokines and CRP, improvement of skeletal muscle performance, improvement of peripheral vasculature, improvement of coronary flow, and finally improvement in left ventricular ejection fraction. So these are the important outcomes of frequent exercise, including just walking from 15 minutes to 30 minutes per day, at least 5 days a week. So in case of acute heart failure, patient, if they are unstable hemodynamics, so no exercise is permitted except some strengthening of muscle strength while they are in hospital. If they are stable, early ambulation program, so they could go for ambulatory exercises, starting with aerobic exercises and going to some walking, especially under control of a physiotherapist. So these are the beneficial effects of exercise in heart failure, positive effects on skeletal muscle autonomic function, endothelial function, neurohormonal function, and even insulin sensitivity in diabetic patients. So all this will lead to improvement in left ventricular ejection fraction. We will go for some selected intervention options in heart failure as non-pharmacological management of heart failure, starting with CRTP or CRT-D. It's indicated in patients with wide QRS complex, especially with left bundle bench block. It's class 1 indication. If patient have wide QRS was without left bundle or with right bundle, still class 2 indication. If the patient is 120 to 140 milliseconds, ICD is option, but CRT-D is still working, and this is according to the NICE guidelines. If we go for ultrafiltration hemodialysis, this actually started since 1970s. There are many randomized controlled trials. Some of them is positive and some of them is negative because of some complications and infections and some mechanical changes due to this ultrafiltration. However, ultrafiltration hemodialysis is still an option for some patients who are resistant to diuretics and in cardiogenic shock or acute renal shutdown. Mechanical circulatory support, there are so many options, therapeutic options in mechanical circulatory support in patients with heart failure. And INTERMAX actually stands for Interagency Registry for Mechanically Assisted Circulatory Support. The purpose of INTERMAX to classify patients with heart failure and delineate them based on their degree of acuity or requirement for inotropic support and clinical status, starting from class 1 with this, which is the worst INTERMAX level, up to class 7, which is the best INTERMAX. So from class 7 to class 1, just discussing LVAD option up to putting on the ECMO or transplantation list. So there are so many grades of INTERMAX from grade 7 to grade 1. There are many options for left ventricular assisted device. Sometimes it's left ventricular only, and with other patients is by ventricular. And you can see here, this is the different uses of left ventricular assisted device. The most important thing to know about left ventricular assisted device is that it's transient therapy, is not a permanent one, especially for patients who are awaiting cardiac transplantation. Main inclusion criteria for LVAD is NIHA functional class 3 or 4, symptoms lasting for 45 days of the last 60 days. Patients are not responsive to good guidelines-directed medical treatment. PVO2 less than 14 milliliter per kilogram per minute. Left ventricular fraction less than 25%. IV inotropic medication for at least 14 days. Intra-aortic balloon support for more than 7 days. So if the patient is having all these criteria, they are indicated for left ventricular assisted device. There is other option, which is veno-arterial ECMO. ECMO is extracorporeal mechanical oxygen, membrane oxygen exchange, and this is one of the recent for patients who needs mechanical circulatory support. There are so many different types of ECMO, including VA, which is the commonest, VV, and VVA or VAV according to patient clinical status. Another type of mechanical circulatory support, which is considered as percutaneous left ventricular assisted device, is the Impella. We have three types of Impella, 2.5 and CP, and then 5. They are all different according to duration of support. 2.5 hours to days, while 5 days, 2 weeks. Again, this is only transitory support until the definite or definitive treatment is reached, which is in most cases cardiac transplantation. This is the guidelines for having either transplantation or putting the patient on best circulatory support. And here how to put the patient on the waiting list for LVAD within those patients would be in need for transplantation later on. Another option is mitral clip, which is recently used in patients with heart failure. Those are the types of mitral clip systems in patients with functional or degenerative mitral regurg. And this is the fluoroscopic images of transesophageal echo probe of mitral clip system. As you see here, this is the fluoroscopic images. This is 3D image, and this is transesophageal 1. And this is the indication of mitral clip. Patients with heart failure with reduced ejection fraction with the severe functional mitral regurg, it should first be on guideline-directed medical treatment, CRT if indicated. If the patient is not optimal, medical treatment should be optimized. If the patient is not responding, we should put them on LVAD indication. If they are indicated for LVAD, so go for LVAD. If they are not, you should go for mitral valve surgery if the patient is fit. If patients are not fit, so they could be fit for mitral clip. Generally accepted indications for transplantation with destination therapy in patients with stage D heart failure. In the stage heart failure, not amenable to other medical or surgical therapies, that limits 1 year survival less than 50%. You have functional class 3 or 4 symptoms of optimal medical treatment. Age is generally 65 years or younger. Healthy apart from heart disease. Emotionally stable, well motivated to resume active lifestyle, compliant with medical advice, with good social and family support. Finally, we have regenerative medicine for heart failure, and as I said in the introduction, it is still in the infancy phase. Stem cell types clinically applicable in heart failure, embryonic stem cell induced pluripoint stem cells, skeletal myoplastis, and some other mesenchymal stem cells, which usually come from bone marrow or other places from within the body. Potential modes of action of stem cells in heart failure, either replacement therapy, cardiomyocyte differentiated from stem cells in vitro, paracrine or autocrine effect for neovascularization, or cytokine therapy for activation of intrinsic cardiac originator cells. So my take-home message, patient can help himself or herself when they have heart failure by being obedient to regular exercise, self-monitoring and management with diuretics, daily weighting, which is very important to assess the fluid status, and compliance with medical treatment. There are so many intervention strategies for heart failure management and pharmacological treatment of heart failure, like CRT, percutaneous treatment of secondary MR, transcatheter aortic valve replacement, ablation in fibrillation, ventricular tachyarrhythmia, extracorporeal ultrafiltration in overloaded patients, ventricular assisted device, and finally heart transplantation. This diagram, I got it from the AF guidelines, and I did some changes here as regarding heart failure nurse here and AF team. All the rest is for AF. And I think clearly that it applies also for patients with heart failure. So patient-centered approach, family carer, cardiologist, pharmacist, general practitioner, heart failure nurse, then all around AF team, EP team, neurologist, cardiac surgeon, physiologist, psychiatrist, nephrologist, dietitian, physiotherapist, endocrinologist. If they work together very well to improve patients' outcomes, I think morbidity and mortality will be different and much better than before. Thank you very much, and I hope all of you.
Thank you, Dr. Ahmed. And for the sake of time, and because we are having broadcasting from the United States on our upcoming sessions, we will move to the next speaker, Dr. Magdi El-Gohari. He will present the wrap-up of this case and the take-home messages. Thank you, Dr. Magdi.
Thank you, Dr. Tariq. Thank you, Mr. Chairman. I'd like to summarize our case, and this is the rule of this talk. Only I will, after all of this discussion, I will stress on 3 points only. The first point is the pathophysiology of the heart failure. The second point is 2 points in the management of the patients, either pharmacological treatment, and the second is the interventional treatment. That's to summarize our case. Let's check our case briefly. The patient is 60 years old, male, manual worker, heavy smoker. He's diabetic, hemoglobin A1C is 7%, controlled hypertension, dyslipidemic, LDL 70 milligram. He had history of PCI to the LED and LCX, patient dyspnea grade 3 to 4. Ejection heart rate is 60 beat per minute, sinus rhythm, narrow QRS complex. Ejection fraction is 35. This is the summarization of our case. Regarding the etiology, from our department, we had done some researches for the etiology of heart failure. We found some changes in the protein amino acids sequences of patients with heart failure. We analyzed by protein analysis and gene therapy. This one paper published a few months ago from our department, and this it showed the gene structural changes in our patients with heart failure. There is the most, I'm sorry, maybe the GG genotype, we found the genotype is most significant change there. The other one is also protein changes. This paper was published last month. We found some changes here in this electrophoresis, 3 amino acids, leucine, methionine, and phenylalanine. This is regarding the pathogenesis, and this work done in our department. The second is the treatment. Regarding the treatment, I think thank you. Regarding the medical treatment, let us summarize in short the medication received by the patient. After all of this discussion, I think we have we have to add sacubitril valsartan. Regarding the other option of treatment is the empagliflozin. Until now, we don't have head-to-head study regarding the comparison of empagliflozin and sacubitril valsartan. So we can use either, but because the patient is diabetic, we can choose empagliflozin. It will have a good effect as regarding long-term effects. The second treatment, we changed the anti-hyperlipidemic from rosuvastatin 40 milligram to Rosova plus ezetimibe in this case. I think because you changed the medicine or you added empagliflozin, which may increase LDL. But I do believe we have to wait because the LDL is 70. So just on follow-up, if the LDL is still low, so we don't have to change because Rosova is very, very high dose. You are using 40 milligram. So I think 20 is enough, or just wait and see. This is regarding the medication. We can use empagliflozin instead of valsartan sacubitril because the patient is diabetic and hemoglobin A1c is 7%. Regarding other medication, we have a long history of discussion, so we will stress on one point regarding the intervention. Intervention from Dr. Ahmed's session, we will take 2 points. The exercise, because exercise definitely will improve heart failure symptoms. This is one crucial for the patient, one step crucial for the patient. The second, this patient is not classic for CRT because the QRS is not wide. Other intervention for recanalization of coronary arteries are not applied for this patient because stress echo was negative. But the ICD is nice for this patient because ejection fraction is 35, and from MEDIT trials, MEDIT 1, 2, this patient will get some benefit, or definitely he will get benefit, not from CRT, but from ICD, for prevention of the long-term death because of VF and VTAC. The third point is mitral valve clip. A lot of discussion. This question, 2 years ago, I was in France, Hospital Charles de Gaulle, and this Dr. Alain Crépier. This man is Alain Crépier, who invented TAVI. At that time, somebody asked him, what do you think about the future of mitral valve clip? Because he invented TAVI. He said no. It will not give good results like TAVI. But medicine is evidence-based medicine. Okay, so let's check from Everest trial. Here, I think this is a start. For our case, it is mitral regurg secondary to LV dilatation. So Everest trial is okay. Head-to-head regarding mitral clip versus surgery. And good benefit regarding mitral clip, but and no difference as regarding deaths. But the rate of surgery after mitral clip was higher than surgery patients. The second point here, this is on the left, lower left, the table showed the steps or the procedures depend on these steps to choose patients for mitral clip. regarding which trial support the procedure of mitral clip, we have MITA-FR, MITRA-FR, and COP trial. Previously, Dr. Ahmed Magdi mentioned these trials. And as we see, the success rate in MITRA was 95.8, only 5% away from 100% in their patients. And in COPT trial, which is more successful, 98. So only 2 patients. But regarding the deaths, no difference in both groups or in both studies. However, the success regarding COPT came from rehospitalization was less in their patients. And the exercise or the patient walking or the physical activity was better in COPT trial. That's why the FDA approved the use of mitral clip for patients with mitral regurg, secondary mitral regurg. And this slide will summarize how to manage patients with secondary mitral regurg. If the patient had secondary mitral regurg with ejection fraction above 30, the best option is surgery. Number 1 is surgery. The best results came from surgery, not from mitral clip. But if the patient is not suitable for surgery, medical treatment is number 1. We have to maximize by exercise, by sacubitril, by empagliflozin, by diuretics, whatever you choose for your patient. If medical treatment fail, so in that case we can use mitral valve clip. I think this is to summarize our case, and I hope I could successfully collect all the discussion about our case today. Thank you very much.
Thank you, Dr. Magdi, for your excellent presentation. As you've said, this patient is a high-risk patient with heart failure with 6 risk factors. I would like just to ask you about the treatment prescribed for diabetes. Which treatment this patient received for? Because you know some drugs have a cardiovascular risk, particularly in this patient. Nohafin.
This patient. Treatment, the patient was receiving metformin, and I think according to the guidelines of treatment of diabetes, this is the number 1. But recently, empagliflozin actually, for this patient, is very, very ideal. Even better. Definitely, patient is heart failure.
Not actually better, because you know that metformin is very important in diabetes, as well as in patients with heart failure. Because it decreases mortality and incidence of rehospitalization. So you can give both of them.
In addition.
And there are tablets of combination of empagliflozin and
of course, metformin.
Thank you.